You are listening to the Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Petersen and Paula Cook. Welcome to the Addiction Files. We are thrilled. Back by popular demand, we have Dr. Mason Turner joining us to discuss personality disorders and also the role with addiction. So I'm just going to turn it over to Dr. Turner. He will just briefly introduce us, but if you have heard him before, you're going to be really thrilled for this episode. And we're just going to sit back and listen and learn. So, Dr. Turner.
Great. Thank you so much. And I'm Mason Turner. I'm the Senior Medical Director for the Behavioral Health Clinical Program at Intermountain Health based in Salt Lake City. And I've spent a lot of my career learning from and learning how to work with patients with personality disorders. And I'm really thrilled in your interest in the topic and understanding more about how we can actually best treat these patients as they come into our clinical treatment environments.
Thank you so much. So start us off a little bit. Explain to us first, what are personality disorders and how do we classify them? And then also, how has this changed? I know there's been these proposed changes going from the DSM-4 to the DSM-5. How is this morphing? So kind of go from there.
It's a great question. And I think just to level set for everyone, it's really important to recognize that personality disorders are a different type of a psychiatric or mental health condition than we might treat these episodic mood disorders and anxiety disorders. Oftentimes, people try to combine the two or think about similarities between the two of the disorders. But frankly, most of what we treat in the psychiatric world in our mental health departments is really those episodic conditions like major depressive disorder, bipolar disorder, psychotic disorders, and those types of disorders that many of you are familiar with. Typically, those are episodic, meaning there's intermittent periods of recovery between episodes, or there's improvement, and then maybe there's some worsening of the symptoms over time. But there are these kind of variable courses with these illnesses that we think about. Personality disorders, on the other hand, are what we call pervasive disorders that affect someone really throughout the lifespan. Some disorders are worse kind of in the earlier parts of life and better later in life, like borderline personality disorder. Others really do present throughout the entire lifespan. And so, in treating and coming up with treatment plans for how best to help these patients, it's a very, very different approach. Many patients with personality disorders don't know another way of being in their lives and may not actually see that some of what they're really struggling with, that there are alternative ways of thinking about some of the problems that they're working with and that they're trying to cope with. And so it's very important when we work with these patients to understand that personality disorders are a lifelong, constant day in and day out struggle for these individuals, not the episodic, but severe episodes that we'll see with other mental health conditions.
That's really interesting. And I'm sure you're going to get to this, Dr. Turner, but what about the onset of these conditions then? If it's a persistent lifetime experience, when do we see them emerge? And especially we see adolescents in our practice, but at what point can you say this really looks like a personality disorder versus, developing brain, adolescent brain, substance use versus mood disorder?
Yeah, so basically by diagnostic criteria, you can't diagnose a personality disorder prior to the age of 16. And partly the reason for that is that you want to see a pervasive pattern of developmental issues that then result in this personality disorder. But I would also say that a large part of what we diagnose, particularly certain personality disorders like borderline personality disorder, even narcissistic personality disorder, may look like your everyday adolescent that you're coping with at home. Your 13-year-old, your 14-year-old, a lot of those characteristics are shared, and they'll quote unquote grow out of them. As those frontal lobes develop, as those impulse control circuits become more fully toned and more active, they will then grow out of those and their personality will evolve and change. And anyone who's raised kids knows that to a degree. There's a lot of activity between 14 and maybe 20, 22 years of age in terms of development and developing those impulse control circuits. What we see with personality disorders, particularly borderline personality disorder, you'll typically see that present usually in the late teens or early 20s. And the reason why is because, one, that's when the personality is becoming more set. So we can say with more confidence that these are personality traits that will persist. And these are personality facets, if you will, that will be with the person for much of their lifetime. And so we began to see the diagnoses increase during that time period. But more importantly, people themselves, as they begin to move maybe out of the households in their late teens, early 20s, or as they begin to get into relationships, which are really big triggers for a lot of individuals, we then begin to see that personality symptoms and that pathology really come out. And so many times that's when we're diagnosing borderline personality disorders. Now, some of the other personality disorders that we may recognize as being maladaptive traits of interactions with others and relationships and what have you, things like obsessive compulsive personality disorder, even some of the other ones, paranoid personality disorder, even schizotypal and schizoid personality disorders, some of which may be familiar to the audience, those oftentimes are never diagnosed. And I have worked with patients who are in their 60s or 70s and said, if I look back over my lifespan, I really had these personality pathologies, as it were, that existed throughout my 20s, 30s, 40s, 50s, 60s. And it's just now that I'm beginning to understand why and how that's all come together. And that is a very common situation that we run into.
So can you just explain what is what means the criteria for borderline versus paranoid personality disorder? And classically, you know, 20 years ago when I was in medical school, we placed them into those clusters. Do we still classify them that way? And what are those different types of classifications? You want to explain that to us?
Absolutely. And we do still have the clustering of personality disorders, which is a useful construct to a degree. And really, most of the time we talk about the clustering of personality disorders, it's that borderline narcissistic antisocial cluster that we think about the most. In terms of diagnostic criteria, I would encourage all of your listeners to take a look at the DSM-5, read through those criteria. They're lengthy. They actually try to capture a lot of symptoms, a lot of dimensions of personality that are really important. I would also say that in common practice, those diagnostic criteria are not very useful. And the reason why I like to say that given enough stress, any of the three of us on this podcast right now could probably look like we have some borderline traits. And we may think back to maybe it was a rough day that we had. Maybe it was a long day we had without sleep or a period of time that we were going through a lot of stress. And our coping mechanisms, our ability to use those executive functioning, those higher level frontal lobe functions do become compromised to a degree. And so then we do have some of those traits that we might see on other borderlines. The key is that it lasts a day or two, and then, or maybe longer, maybe a week or two, but you do kind of come out of that and you actually are able to get back to a more adaptive level of functioning. So that's the first piece diagnostically I'd really encourage your listeners to think about is not the point in time that you see the person, especially if you work in an acute care environment, never diagnose a personality disorder in the hospital, medical, behavioral health, or otherwise. None of us are at our best in the hospital. So we really want to think about what are those longitudinal personality characteristics? And then really, what are we seeing across the board in a variety of different settings, low stress, high stress, hospital, outpatient, and so forth. So think about the longitudinal aspects of that. And I really don't diagnose personality disorders with any of my patients until I've known them for about 6 months typically. And again, the reason is I want to see them in a variety of situations, under a variety of circumstances, and understand how they respond and react. So that's the first diagnostic piece I would put out there. If we want to drill into this a little bit further, what we find, say, with a borderline personality disorder or pathology, as I sometimes use that term, we see a lot of relational issues, a lot of being triggered in relationships with other individuals, fears of abandonment, overreading or overreacting to cues they're seeing from individuals in their lives and thinking that they're saying something negative about them rather than something positive. As we would say, the negative valence around those interactions becomes very prominent. And there's been a fair amount of research that really looks at how borderline patients or patients with borderline personality disorder actually view a social situation versus someone who doesn't have that condition. And they see more of that negative valence, more of the negative interactions, more of the negative perspective from that other individual. And we do see that clinically quite a bit. So that's another one of the diagnostic pearls that I think about. But really, it's about those relationship interactions and then a lot of chaos in those relationships and a lot of reactivity in those relationships. We oftentimes say that patients with borderline personality disorder, if we could actually remove them from all of their relationships, which of course is not possible, they probably would not have the condition. So, very much based in relationships, and it's based in relationships with their clinicians as well. So it really is about any relationship in their life and then overreading some of those social signals that we might otherwise not overread. And then finally, with borderline personality disorder in particular, we do see a lot of self-injurious behavior as a way to express, to get out some of the psychic pain that those individuals are sensing. And we can talk about further if you want to dive into the difference between self-injurious behavior, suicide attempts, suicidal thoughts, and what have you. And there is a spectrum there we have to think about. But I'm always very interested to know, how are they using self-injurious behavior in a way to relieve their psychic pain? And that gives you kind of a window into the personality pathology as well. So those are some of the major categories and ways of thinking about borderline personality disorder. Narcissistic personality disorder, which is closely related to borderline personality disorder, is really more of an issue around self-esteem. We might say, if we dial this back 50, 60, 70 years, we might think of narcissistic personality disorder as a more of a getting closer to the neurotic level of functioning, to use some very old terminology. Moving from the borderline psychotic condition that was described by Freud and some of his contemporaries over 100 years ago, to more of the narcissistic pathology, where there's really that idea of a low self-esteem. And narcissistic patients oftentimes will actually want to bring others down in order to feel better about themselves, or conversely look for ways to actually promote some of their own activities and actions as a way to help them to feel better about themselves. But at the core of a narcissistic personality disorder functioning is this idea of low self-esteem, and the idea that they really cannot internalize things about themselves that maybe the rest of us would be able to say, that's really something special about what I can do, or the way I can perform or achieve. And so that's at the core of that particular personality disorder, highly related to borderline, but also a less relational chaos and that type of thing. And oftentimes, narcissistic patients really cannot tolerate being in a relationship with someone else because of the way they are triggered in terms of their self esteem. And then finally, from a diagnostic perspective and a treatment seeking perspective, antisocial is another that we actually see some in clinical practice as well. If you are working in a carceral setting, or prison or a jail, you most certainly are seeing a lot of antisocial personality disorder. And that is really characterized by a lack of empathy. And we could spend a long time kind of unspooling that, and really the origins of antisocial personality disorder. The other names that it goes by, psychopathy and sociopathy, are closely related, not quite the same thing. But these are all part of this idea of not being able to empathize with others. And so some of those circuits that allow us to empathize, experience what someone else is experiencing, really are not as active in those patients as well, oftentimes leading to crime, leading to violations of law and what have you. But at the core of it is a lack of ability to understand or express empathy. Empathy is understanding the emotions of another person that you have never experienced yourself. And so, again, that's a really key part of being a human being to a certain degree. But then also, we know that there are neurological underpinnings and neurobiological underpinnings for empathy that really we have to think about.
So I have a question about that. Is there a anatomical basis for lack of empathy or sociopathy? Or is it inherited? Or, I mean, this is maybe a broader question about all of personality disorders, but particularly this personality disorder. And is it affected by substance use? Because I see people in jails, and sometimes I just wonder if their frontal lobe is just offline, and they have the inability to empathize or really identify with the consequences or what they've done. And if it's the substance use, speaking, or if they have some of this kind of sociopathy, antisocial personality.
Yeah, so in terms of the neurobiological underpinnings, we do know a couple of things that I would point out for your listeners. So, first of all, we do know that personality resides in our frontal lobes. That is actually where our executive functioning lies, our ability to actually go from point A to point B, to plan a lot of the things that we identify as being very human and distinguishes us from dogs or cats or others, really resides in that frontal lobe. And that's really where impulse control also resides. Now, in terms of, can we map that down to individual personality disorders, there have been a lot of efforts looking at that, in terms of how we can look at individual circuits. And some of that work is very interesting. I would say that we're not at the point of being able to actually identify what circuit maps to which personality disorder. We do know that frontal lobe functioning is impaired in most personality disorders, if not almost all, frankly. Other important areas that we have to think about, though, is the limbic system. And the limbic system is the middle part of our brain, and is responsible for driving emotions, aggression, love, sex, all those kinds of things really do reside to a degree in our limbic systems. Very important for emotional reactivity, very important for feeling emotions, experiencing them. It's actually a very positive part of our experience. It's a very positive part of our brain, but only when those frontal lobes and the higher levels parts of our brains can kind of tamp down some control over the limbic system. So we do see the amygdala, which is part of the limbic system, is that part of our brains responsible for anger, irritability, even to a degree. Really being able to act on some of our other emotions like sex, hunger, those kinds of emotions really do reside in the amygdala. And we do see the amygdala in particular being implicated with some of our personality disorders as well. When the anger really flares up, when the frontal lobes can't suppress some of those circuits and can't think through the actions of acting on what the amygdala is telling you to do. So, again, we do see some of those circuits that are involved. To what degree we can map them, it's a little bit more limited. And we can talk about some of the research and the reasons why we have trouble with research into these disorders in particular. But definitely there are neurobiological underpinnings. Your question about substance use is really interesting as well. And there are a lot of schools of thought around this, including my own, depending on the patient. I think we do want to think about individually how patients come to us and how they actually come to the pathology they're having to actually deal with and manage. And the quick answer I would say is that typically we think the personality develops first before substance use. And that oftentimes the substance use is a way to actually manage some of the feelings and the experiences that the person's having. That is by no means the entire answer, though. We know these are bidirectional relationships. We know that actually substance use and personality kind of fuse together, particularly in the adolescent brain sometimes. It may take years to unwind over time, and being able to get into long-term recovery involves unspooling some of this and maturing and growing some of those impulse circuits and ideas and those kinds of things. So there's a very complex relationship there, but personality tends to be set much earlier in life before people start using substances.
That is just so fascinating. Thank you. And just going back a little bit, I really appreciate your advice that you really get to know a patient and see them in times of high and low stress before making that diagnosis of a personality disorder. I think that's really important advice because I will see patients sometimes coming out of a treatment center with these diagnoses of personality disorder. And I think it's sometimes hard because they clearly have only been in a high stress environment. So I think that helps us to try to see these patients in varying situations before we make that diagnosis. And my next question is, how common are personality disorders in the general population? And then piggybacking on that, and how common in our substance using population?
Yeah, so it's interesting if you look at both the treatment seeking population as well as the overall general population. And obviously, if you've never sought treatment, the ability to diagnose a personality disorder is going to be difficult, right? So we have some ideas around the total general incidence of personality disorders. And in some cases, for certain personality disorders, particularly the avoidant type of personality disorder, and some of the ones that really don't have as much in the way of functional consequences, estimates are up to a third of people have those personality disorders. Now, it begs the question, once you're identifying a quote unquote disorder in a third of the people in the population, is that really a disorder? Or is that really a variant of human behavior that we're trying to call a disorder for some reason? So, those are questions I always like to ask because, again, a third of people should not have a disorder at baseline. So, for me, the question is really who is seeking treatment? Because treatment seeking behaviors really, to me, they tell you a lot about the functional impairment. They tell you a lot about why people come in and try to relieve their suffering and discomfort, right? So if we look at that treatment seeking population, actually, the general population has about an 11% rate of borderline personality disorder. If you then look in the treatment seeking population, depending on the study you look at, up to 50% of the treatment seeking population has a borderline personality disorder. In addiction programs, that number is probably between 35 to 45%. Now, there are a lot of caveats to this data. First of all, using the diagnostic criteria to actually diagnose a personality disorder is frankly very challenging. And you have to have a lot of expertise in using those criteria in a clinical interview in order to accurately apply them. So some of this could be overdiagnosis. Some of it could be you're not your best when you enter some of these programs, and maybe there was a reflexive diagnosis that occurred. But I would say that we can say pretty reliably that 3 to 4 times the incidence in the general population versus the treatment seeking population for borderline. Narcissistic personality disorder, we tend to not see those individuals seeking treatment as much, but we also know that probably there's a similar pattern there as well if we really dug into the data and the incidence and what have you. Antisocial personality disorder, those individuals typically are seeking treatment because they're court ordered to do so or they're in jail. And so if we look at those particular populations, again, depending on your studies, up to 60% of individuals in carceral settings have antisocial personality disorder. And you can conclude that that's just a natural consequence of having the personality disorder. That is one way to think about that. I'm actually more interested in thinking about why is that the natural consequence of antisocial personality disorder? And where have we actually failed the patient in trying to intervene and get them help earlier in the course of their illness before they're then in jail or in prison? So that's kind of another way to think about that particular disorder.
And is this true, Dr. Turner? Of all the personality disorders, antisocial personality seems to be the one that has the earliest onset. Like sometimes they'll see the trait around 10 or 11.
Of stepped diagnoses getting to an antisocial personality disorder that we do not have for, say, borderline, which has to do with a conduct disorder, which is more prevalent in earlier adolescence prior to the age of 16. Even disruptive behavior disorder is considered by some to be a precursor. But the conduct disorder is really the one that most accurately predicts the evolution to
Yes.
antisocial personality disorder. That, by the way, conduct disorder is very straightforward to diagnose. And I think that that is probably underdiagnosed in our adolescent population. I will say with a caveat that not all patients with the conduct disorder will develop antisocial personality disorder. So just keep that in mind. But that is certainly something that we do see. The conduct disorder does precede it.
Is there a heritability aspect to personality disorders? Do you see this run in families? And do we think that's a genetic? Is it a nature versus a nurture heritability situation?
So there's definitely heritability aspects to this. And I think if we talk a bit about, again, borderline has been the one that's been most well studied in this regard. If we look at the heritability aspects, it is very difficult to disentangle the genetic from the trauma basis from what is actually being raised in a household with someone who has borderline personality disorder. I will say in my clinical practice, again, I can't really cite research on this, that I actually don't see that much heritability of borderline in particular, because I think that there is this idea that there's a trauma genesis that occurs, and most borderline patients can identify some significant trauma that actually started the personality disorder to a degree. And if the child does not share that trauma, the likelihood they will develop that personality disorder is much less, in my opinion, in what I've seen clinically. So I think we have to separate and tease out some of those issues as well. And the trauma model really have to think about that and how that interacts. But there are definitely genetic components that we have to look at. There are definitely heritability from the environmental perspective as well. And then that trauma genesis piece as well is really important to keep in mind.
Let's talk about that. What is the role of trauma in personality disorders? How many of them have that genesis from trauma? And how much of it is that the one of the, how common is trauma the root cause of a personality disorder?
So I would say in my 25 years of clinical practice and working with patients with borderline personality disorder, I've probably met 5 in my career that didn't have some kind of trauma in the background that we could identify. Now, what's interesting about the trauma piece of this is that if we think about the development of personality, we have to think about trauma as being an interrupter of the development of that personality. So if I have trauma, a significant trauma experience at the age of 2 or 3 or 4, for example, my personality trajectory is going to look a lot different than if that trauma comes up at 9, 10, 11, 14, 18. So first of all, my first piece of information I want to know is what was the nature of the trauma and when did it occur? And then you can begin to look at how that comes out in the person's personality. So for example, if I'm working with a patient who had severe sexually based trauma starting at age 2, 3, or 4, what I might expect later on is a very difficult period of attachment issues, really having a difficult time having, really feeling that paternal attachment to anyone. Becomes a big issue, those types of issues, because they never developed those skills because that trauma really interrupted the development. Whereas if we see someone who's traumatized at age 14 or 15, we're going to see a different set of impulse control issues, perhaps, or a higher risk of addiction and what have you. So that's my first idea. First question is, when did the trauma occur, and when was it most significant? To give me that window into how I'm going to see that show up later on in that person's personality development. I would also say, if we think about trauma again with that idea of an interrupter of personality development, it also is an interrupter of developing of impulse control. Impulse control, we think of as being an adolescent phenomenon. They develop impulse control as an adolescent. Well, for those of you with young children who have kids sitting in a circle in preschool, that is impulse control. Toilet training, very famously by Freud, was considered to be a form of impulse control and reactivity against your parents for requiring impulse control because you had to actually learn how to use a toilet, for example. So impulse control also develops throughout the lifetime and throughout childhood as well. So we have to think about when the trauma occurred from that perspective as well. So again, personality development, impulse control development, and then finally, what were those parental relationships like? What were the friend relationships like? The familiar relationships? That will tell you about the social and relational aspects when trauma interrupts that particular piece of development as well.
Great. Thank you so much. How do we even begin to treat personality disorders?
So I would say the first thing I'd like to tell your listeners around treating personality disorders is, for a minute, when you're sitting with someone who maybe you're what we call countertransference is being activated. Countertransference, by the way, is the feeling that we have in a patient encounter towards the patient. We all have had issues of countertransference. We may have them frequently when someone is, quote, pushing our buttons, or someone is saying things to us that are really riling us up, or maybe they're not grateful for the care that we're providing, or some way we feel that that relationship with the patient is really challenged. That actually in of itself is a sign of personality disorders. That's partly what I put out there. But I would encourage you, rather than kind of thinking through that as being a source of irritation with the patient, or a source where you feel like the patient isn't trying hard enough or is rejecting help that's being offered, for just a minute, try to put yourself into that person's head for a second. As we say in a very shrinky phrase in psychiatry, sit on the same side of the couch as the patient rather than the opposite side, and try to understand what it would be like to be at that level of functioning with those particular issues that are coming into that clinical encounter with you, wherever that is. That's part of empathy development. But for me, it's also part of saying, how does this person see the world? What are their perspectives? What are the relationships and the things they're really working on? How can I help them set some goals for themselves and understand really what are they coming to the table with, and how can I respond to that, rather than responding from my own internal experience, which is very different than the person sitting across from me. We tend to do that pretty regularly in clinical care, but with personality disorders in particular, we can fall into that idea of really being much more into ourselves and trying to look at our own experience to inform how we interact with someone. So, first of all, step out of yourself for a second, try to sit on the same side of the couch as your patient. Once you've done that, I think it does change things up a bit and helps you to understand the next steps in treatment, which I would say there are kind of a couple of things to think about depending on where you are and what type of treatment you're providing to patients. One, psychotherapy is always going to be the treatment of choice for any personality disorder, period, full stop. Access to evidence-based psychotherapy treatments is also very limited, period, full stop. And so I think we have this really difficult situation. We have patients coming in who are suffering tremendously, possibly with a lot of hospitalization, suicide attempts, and so forth. We know that psychotherapy is going to be the treatment of choice for them, but they can't actually access that treatment. It's gotten a little better over the years as we've had dialectical behavioral therapy, some other evidence-based treatments that actually can really target the source of some of that borderline pathology, but access to those treatments is still quite limited. And so we have to think about, okay, we have this option, let's try to pursue that, but then we can also manage symptomatically with medications as well. I do tell people working with borderlines in particular, they will have every symptom in the DSM-5 either on presentation all at once or over the course of their treatment. So you may end up with 15 different medications. Please don't do that. Try to choose one target symptom that's bothering the patient the most: insomnia, anxiety. Try to limit polypharmacy. Try to find Occam's razor where you can use one medication to treat several conditions at once. But really try not to get into the polypharmacy trap with these patients, because then we actually see a lot of issues of disinhibition, medications interacting and not working well together. and even addictive behavior around use of prescription medications as well. So those are usually the first steps in treatment. Psychotherapy referrals, understanding what's available in your area and available to the patient, and then symptomatic medication management.
Tell us some advice about group therapy and who does well with personality disorders in groups, and what are some cautions? How do you proceed with that, especially with our substance using population? Because in residential treatment and inpatient, we just seem to have a one size fits all. Everybody goes to group, but not everyone thrives in that setting.
That's right. And I think I would first say specific to borderline. So we'll start there and I have some other comments for the other personality disorders as well. But starting with borderlines, you will hear a lot in all kinds of clinical settings. This person has no boundaries and they just need to have boundaries. We need to set some boundaries for this patient. Well, guess what? No boundaries is, I don't think it's one of the diagnostic criteria, but it should be. There are no boundaries with patients that have borderline personality disorder because they don't have the ability to set them. And so part of our role as therapists and treatment providers is to help with that, to set empathic boundaries. But we've also got to kind of think about how we do that in a way that's actually furthering the treatment and not being punitive. Again, going back to our reactions to the patients when they're in treatment with us, especially in a group where that's all going to be magnified, we've got to really check ourselves and our own reactions to patients. And for me, particularly with those with the most severe personality disorders, I'm doing that on a moment by moment basis in a clinical session with the patient, making sure that before I speak, what I'm saying is not coming from a reaction internal to myself, but is designed to be therapeutic for the patient. And that can be a pretty exhausting process, but it's really necessary. How does that show up in groups? Well, groups by their very nature are heavily boundaried environments, or they should be, and patients can't monopolize the conversation because other people are in the room. And so, if you're going to have an open, what we call a process group in the field, people share their concerns, they get feedback from other patients, that could be a recipe for disaster with someone who isn't able to set their own boundaries. And you get into this adversarial relationship with the patient where you're trying to cut them off, say you only have 2 minutes to talk about something that's very important to you, and so forth. So, patients with borderline personality disorder really do well when you take a strictly skills based approach. And you have therapists who are actually working together to ensure that they are not talking about the crisis of the day, that they're not actually directing a lot of the work that they need to do in individual therapy, where they have all the time to themselves with the therapist, not bringing that into the group. So it takes a very skilled therapist who can recognize that, who can set empathic boundaries and really be able to refocus the group. And typically, when working with borderline personality disorder in our dialectical behavioral therapy groups, we recommend 2 therapists for no more than about 8 patients. So you can see it takes a lot of effort, but it's really important. And then over time, just as when we work with many people in setting boundaries, those impulse control circuits are toned up. People recognize what they need to do to set those boundaries, and we see some kind of self-management of those boundaries moving forward, but that takes a while.
That is really great advice. And I
Yeah.
think that's a really good setup.
That's really helpful just for not only group settings, but for individual interactions with people. Because sometimes, like you were saying, you really take a moment by moment approach to check in with your own internal reactivity when you're working with patients with personality disorder, especially borderline. That's very helpful. Because sometimes, I don't know, I sometimes just feel immersed in the situation, and it's good to be able to remember to slow down, try and imagine what they're experiencing and respond really carefully without being
That's right.
punitive. Yeah.
It's really important. And I think also keep in mind from the what the personality pathology is that's driving some of these behaviors is a lack of trust and feeling even worthless in some cases, feeling
Mhm.
like there's no ability to attach because I'm going to attach to someone who's just going to leave me. In the case of maybe early parental issues that happen, early parental trauma. So the natural inclination in a clinical encounter is to try to find ways in which to prove that hypothesis. Right. So someone who has borderline personality disorder has spent their entire lives really being hyper acutely aware of trust issues and when am I going to be abandoned next? And because they live in that world so much, when they come into the clinical environment, they expect you as a clinician to abandon them. And in many ways, actually, will reach for that. They'll say, well, let me make sure that I actually am in control of when the abandonment occurs. So they pull from us to actually abandon them, to actually do things that kind of prove that hypothesis. And if we can step out for a second and recognize that and say, let's keep that in mind as we are talking to the patient, as we're making decisions around medical care and what have you, it really does help quite a bit, particularly in the non-mental health environment where you don't have time to be able to go through this in a lot of detail, but you can recognize that a request coming from the patient for something that may not be medically indicated, the way you respond back to that is going to be very important in terms of how you say no to that patient and how you can thoughtfully say no to the patient in a way that is seen as empathic and not seen as abandoned.
That's great advice. Anything else we haven't covered?
I would just say a quick word about working with patients with narcissistic personality disorder,
Yeah.
which frankly don't pull quite as much in terms of your response as a clinician, but can be also very difficult to work with in the group setting. It is very important to be on the lookout with these patients in group settings for that cutting down of other individuals, denigrating of their accomplishments and what have you, because that's actually the way people with narcissistic personality disorder derive a lot of their self-esteem. So again, you're looking out for what is that group process and really being hyper aware and keenly astute in terms of what's being said in the group. And it is exhausting. That's why we have multiple therapists working with those patients as well, because we've got to attend to what's being said in a very careful and deliberate fashion and also set boundaries as well around what are we all doing here? What is the purpose of this group? We're here to learn about addictions. We're here to actually learn how we can get skills to, get into recovery and what have you. And so keeping that focus is super important. And it really does take a lot of very intentional work to be able to do that.
Dr. Turner, so do you think it is applicable across all personality disorders to really use more skills-based groups rather than process groups, even in correctional settings? So if we do groups in the jail, for example, stick with skills-based groups rather than kind of strength-based groups or process groups, especially if it's not being run by particularly skilled facilitators. Like we don't get group training, right, in medical school. You do as a psychiatrist, but we don't. And if we don't have therapists to help us run some of these groups.
So generally speaking, yes, you were really focused on skills-based groups. And this is actually true across a range of different diagnoses as well, not just personality disorders. Why this becomes really important, I think, with personality disorders is because you want to, one, define what is the purpose of treatment. As I mentioned earlier, a lot of personality disorders don't come in for treatment, and that's because they don't sense the need. So, first of all, my first question when I'm working with someone with, say, an obsessive compulsive personality disorder or even a paranoid personality disorder to a degree is to say, how is this working for you in your life? Many people will say, you know what, certain people are just not as they're not thinking about the role of government, other people in terms of how they're monitoring me or how they're using the IRS or whatever the conspiracy theory is that someone with paranoid personality disorder might have. They'll say, I'm perfectly fine with that. I don't need any help with that. And so as a clinician, I really have to understand what is the functional problem I'm trying to address. More often than not, that is going to map to some skill that I can actually work with and teach a patient. And so I think being very intentional about not only the diagnosis, but what is the functional problem I'm trying to address? And then how do I map the treatment to that functional problem? And again, typically skills based work is going to do that the most quickly and the most effectively. Process groups are important for other types of patients and with other goals in mind. But in general, as we're working with the more severe mental illness, for example, and personality disorders, we are wanting to focus on the skill development.
Thank
I would
you.
also I would also add with the skill development fits in nicely with the neurobiological model of hypotonic frontal lobe circuits because skill development and really working those frontal lobe circuits in a cognitive fashion will also tone up those circuits as well. So again, not scientifically based yet, that's my hypothesis, but having worked with a lot of people over the years, I do find that they actually really respond well to those skills-based treatments.
Well, I think especially in early recovery, where that's where we're treating a lot of people's substance use and these
Right.
personality disorders. That makes so much sense.
Yeah, and like you
Really,
said, if it's emerging from the limbic system, having skills that you can just automatically employ without having to engage more executive functioning to think, well, what should I do in this situation? You can just pull out a skill to try and use when the limbic system's trying to be in control. I could see how that could be helpful.
And to that point as well, I've had patients who take this on Post-it notes, even write down some really basic skill they may have learned in therapy, but they put it on the mirror in their bathroom so that when that limbic system or amygdala really gets engaged, they see the skill on the Post-it note and say, wait a minute, I think I've got amygdalar hijack. So I love that term. My amygdala is hijacking the frontal lobes or the cerebral cortex, and I need to do this to actually kind of get out of that. And that's really, I think, very useful for a lot of patients.
That's great. That's helpful for us. I cannot thank you enough, Dr. Turner. This was fascinating. I learned so much, and I'm sure our listeners appreciate it. Thank you for your time. You're a wealth of knowledge, and we can't thank you enough for coming back.
Thank
Have
you
a
for
great
having me.
night, everybody.
Thank you so much.
Until next time. Hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
Content of the podcast are for entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you're advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on this show are those of the Addiction Files and not of our respective employers.